Usually, when we talk about a medical diagnosis, there's this expectation of, like, mechanical precision.
Right.
You know, you break your arm, the x-ray shows that jagged white line, and the doctor just points to the screen and says, there it is.
Yeah, it's very binary.
Exactly. Broken or not broken. It's visible, it's perfectly categorized, and honestly, it's comforting in its simplicity. But you step into the world of preventive cardiology and specifically lipidology, and suddenly that x-ray machine is totally useless.
Totally.
We're looking at a treatment landscape that is, when you view it through the lens of public perception, entirely murky.
Oh, it is the absolute definition of diagnostic muddy waters for the patient sitting in the exam room, which is, deeply ironic.
How so?
Because the science behind the scenes, like the actual cellular pathophysiology, is crystal clear.
And that disconnect right there between the pristine clinical data and the chaotic public perception, that is our mission today. For this deep dive, we are pulling directly from the clinical notes and articles of Dr. Michael Albert, specifically his Substance Over Noise series.
It's a great series.
It really is. And our goal for you listening today is to extract the hard, evidence-based substance and systematically dismantle the dangerous noise surrounding lipidology. Because Dr. Albert's framing of this issue is blunt, and it is unapologetic.
Yeah, he doesn't hold back.
Not at all. He writes, quote, "The cholesterol wars are over. LDL won."
It's a definitive statement, and, well, it really needs to be.
Right.
I mean, for decades, there was genuine scientific debate. We have to acknowledge that. But at this point in the timeline, denying that low-density lipoprotein causes heart disease or claiming that the human body somehow, needs excessively high circulating cholesterol to function optimally, it's no longer a heterodox scientific position.
It's a clinical hazard.
Exactly. It is a clinical hazard.
And he goes even further than just calling it a hazard. He states that medical misinformation in this specific field has a literal body count. It results in entirely preventable deaths. So, okay, let's unpack this.
Let's do it.
If the science is so completely settled, if the genetic data and randomized controlled trials are unanimous, why do patients still walk into clinics clutching their chests with a family history of early infarction and remain absolutely terrified of taking a life-saving medication?
Well, the resistance largely stems from a void, right? A void in understanding basic cellular mechanisms. I mean, we have never had better data, but we have never had worse public trust.
That's a great way to put it.
And when there's a void of complex information, the internet just fills it with these simplistic, frightening narratives. People genuinely believe they're swallowing this harsh chemical that forcefully scrubs their blood vessels like bleach.
Or poisons their liver.
Right, exactly. Rather than understanding it as a precision tool that just gently modulates their own natural biology. We really have to look at this not as a defense of a pharmaceutical status quo, but as a rigorous accounting of converging lines of evidence. You mentioned genetic data earlier. We now have decades of Mendelian randomization to back up the randomized trials.
Wait, let's pause right there. Because Mendelian randomization is a term that gets thrown around a lot in lipidology circles, but we rarely define it for people outside that bubble.
Fair point.
Explain how genetics act as, nature's own clinical trial here.
So a traditional randomized controlled trial, or RCT, it takes a group of adults, gives half of them a drug to lower LDL, and watches them for 3 to 5 years.
Right. Standard stuff.
And that is highly valuable, but it only shows the effect of lowering cholesterol late in life over a really short duration.
Because they're already 50 or 60 years old.
Exactly. Mendelian randomization, on the other hand, looks at genetic variants that people are actually born with. Some people inherit genes that naturally keep their LDL slightly lower their entire lives.
Okay.
And others inherit genes that keep it higher. By studying massive populations based on these genetic randomizations, which are set at conception, literally day 0, we can isolate the lifelong effect of LDL exposure.
Oh, wow. So it totally eliminates the confounding variables.
Completely.
You can't blame their diet or, their exercise habits or their smoking status because the genetic assignment was completely random.
Precisely. And what Mendelian randomization proves, unequivocally, is that lifelong exposure to lower LDL results in a dramatically lower risk of atherosclerotic cardiovascular disease, or ASCVD.
So it proves causality, not just correlation.
Right. Well, causality.
Which brings us to the first major piece of clinical rigor we really need to reestablish today. We have to travel from those broad population-level genetic stakes all the way down to the cellular level.
Down to the liver.
Right. We need to correct a fundamental physiological misunderstanding that even some clinicians get wrong when they're, doing that shorthand explanation with patients. Yeah. And that is, this statins don't actually lower your LDL, your liver does.
This is such a critical paradigm shift in how we explain the mechanism of action. Because when a clinician is rushed, they often just say, take this pill, it'll lower your cholesterol.
Right, the easiest explanation.
But that shorthand implies the drug itself is circulating in the bloodstream, actively binding to cholesterol, and somehow chemically disintegrating it or, clearing it out through the kidneys.
Like Pac-Man just eating the cholesterol.
Exactly, and that is entirely incorrect.
So let's go down to the hepatocyte, the liver cell.
Right.
I swallow a statin. What is the actual biochemical cascade?
Okay, so a statin's primary mechanism is inhibiting a specific enzyme in the liver called HMG-CoA reductase.
HMG-CoA reductase.
Got it. And this enzyme is the rate-limiting step in what is known as the mevalonate pathway. The mevalonate pathway is essentially the liver cell's internal manufacturing plant for synthesizing its own cholesterol.
Okay.
So the statin goes to the liver, blocks this enzyme, and suddenly the liver cell's internal cholesterol production just grinds to a halt.
So the statin is just shutting down the factory inside the cell. But wait, the liver still needs cholesterol, right? It isn't just a waste product.
Oh, the liver cell absolutely requires intracellular cholesterol for vital functions.
Yeah.
I mean, maintaining cell membrane integrity, synthesizing bile acids for digestion, and so forth.
Right.
Because its internal manufacturing plant has been shut down by the statin, the hepatocyte suddenly senses a deficit in its own intracellular cholesterol pool. It literally thinks it's starving.
It has a demand it can no longer supply internally.
Exactly. And because it cannot make the cholesterol, it has to look externally to the bloodstream to acquire it. So in response to this perceived intracellular deficit, the nucleus of the liver cell upregulates the production of LDL receptors. Mm-hmm. It deploys this massive, newly minted army of these receptors to the surface of the cell.
And those receptors are the true functional heroes of this entire process.
They really are. What's fascinating here is that it's the liver itself utilizing this newly deployed array of LDL receptors that physically reaches out, binds to the circulating low-density lipoprotein in the blood, and pulls it inside the cell to be used.
So the drug is merely a biochemical signal.
Yes. The body's own organ does the heavy lifting.
That completely reframes the drug from some toxic foreign invader into a really subtle biological nudge. It's essentially like a thermostat in a furnace.
Oh, I like that.
Yeah, think about it. The statin is the thermostat. You're just turning the dial to create a deficit. The statin itself isn't generating the heat, or in this case, clearing the LDL. Your liver is the furnace actually doing the physical work to change the environment.
That is a highly accurate way to visualize it. And when you explain it to a patient using that exact analogy, like, I'm giving you a medication that simply tells your liver to do its natural job more aggressively, it strips away a lot of the unnatural mystique that internet forums have placed on these molecules.
Let's layer in another concept here that Dr. Albert focuses on, because if we're talking about what the liver is pulling out of the blood, we aren't just talking about cholesterol mass, are we?
No, we're not.
We have to talk about ApoB. In the notes, LDL and ApoB are treated almost interchangeably as the causal drivers. What is ApoB, and why does that distinction matter?
So apolipoprotein B, or ApoB for short, is the structural protein that wraps around the cholesterol to carry it through the bloodstream.
Okay.
Because cholesterol is a lipid, right? It's fat-soluble, blood is mostly water, and oil and water do not mix. So the body has to package the cholesterol inside a protein sphere just so it can travel.
I always picture it as a submarine. Like the ApoB is the steel hull of the submarine, and the cholesterol, the LDL-C that we measure on a standard lipid panel is the cargo inside.
The submarine analogy is perfect.
Yeah.
And the reason ApoB is the ultimate causal driver of atherosclerosis is that the particle itself, the submarine, is what actually crashes into the arterial wall, gets retained in the endothelium, and starts the whole inflammatory process of plaque formation.
Right.
You can have a patient with a relatively normal amount of total cholesterol cargo, but if that cargo is packed into thousands of tiny, dense submarines, they have a high ApoB particle count, and the risk of a cardiovascular event is exceptionally high.
Because there are simply more physical particles crashing into the artery walls.
Precisely.
So when those upregulated liver receptors pull LDL out of the blood, they are physically grabbing the ApoB protein and yanking the whole submarine out of circulation.
Correct. The receptor binds specifically to the ApoB protein on the surface.
Okay, so if the liver is doing the clearing and the statin is just setting the thermostat to create the deficit, the obvious clinical question becomes, where do we set the dial?
Right.
How much should the liver clear? Because this is where the clinical ground is shifting incredibly fast.
It's shifting rapidly. And to understand this, we have to examine the newly updated 2026 ACC-AHA Dyslipidemia Guidelines.
The new rule book.
Exactly. For a long time, particularly starting around the 2013 guidelines and persisting heavily in the public consciousness, there was this idea that we should just put someone on a high-intensity statin, and whatever their LDL subsequently drops to, we just accept it.
Right. We weren't treating to a specific target.
No, we weren't. It was what you might call a fire and forget strategy. Prescribe 80 milligrams of atorvastatin and just hope for the best.
But that era is over.
That era is definitively over. The 2026 guidelines have firmly course-corrected.
Yep.
LDL-C treatment targets are officially back, and the thresholds are tighter than ever. And I should add, this is backed by Class 1, Level A evidence, which is the highest level of clinical recommendation possible.
Let's break down those specific targets because they're pretty jarring for anyone who trained, say, a decade ago.
They are. So the 2026 guidelines drew a line in the sand for secondary prevention.
And secondary prevention means patients who already have established atherosclerotic cardiovascular disease, right? Like they've had a myocardial infarction, a stroke, or they have stents.
Exactly. For these patients, the target is now an LDL-C of less than 55 milligrams per deciliter.
Sub 55, that is a massive paradigm shift. I mean, 10 years ago, if a secondary prevention patient hit 80 milligrams per deciliter, clinicians were practically popping champagne.
And we now know that was grossly insufficient. Additionally, the non-HDL cholesterol target for these patients is less than 85 milligrams per deciliter.
Wow. Okay, what about primary prevention? The patients who haven't had an event yet, but they have risk factors.
For primary prevention in patients who have a 10-year ASCVD risk of 10% or greater, the goal is now less than 70 milligrams per deciliter.
Using high-intensity statins.
Correct. Furthermore, the 2026 guidelines explicitly recommend initiating treatment far earlier based on subclinical atherosclerosis.
Oh, interesting.
Yeah, if a patient gets a coronary artery calcium score or a CT angiogram, and you physically see calcified or soft plaque in the vessel walls, you do not wait for the plaque to rupture. You treat the disease you can see, driving that LDL down immediately.
Let me play the skeptic for a second, because pushing LDL down to under 55 is exactly the point of friction you see online.
Oh, absolutely.
In some of the trials we'll discuss, patient LDLs drop into the 20s. Isn't there a physiological floor here? I mean, the brain needs cholesterol. The endocrine system needs it to make hormones like testosterone and cortisol. Is lower inherently always better, or are we just obsessively chasing laboratory numbers to the point of risking human physiology?
That is a highly valid biological question. And the scientific community didn't just dismiss it. They tested it head-to-head. I want to point to the Ez-PAVE trial data from Dr. Albert's notes.
The Ez-PAVE trial.
Yes. This trial is an absolute landmark because it was the very first head-to-head randomized controlled trial specifically designed to compare different LDL-C targets.
So they weren't just comparing a drug versus placebo, they were comparing one biological target versus a more aggressive biological target?
Exactly. They took a large cohort of patients with established ASCVD and randomized them into two distinct treatment arms. Group A was treated to a target LDL of less than 70. Group B was treated aggressively to a target of less than 55.
And the results?
The outcomes were definitive. The group targeting less than 55 experienced an additional 33% relative risk reduction in 3-year major adverse cardiovascular events, or MEEB.
Wait, a 33% reduction in major events over just 36 months, simply by pushing the target down an extra 15 points.
Yes.
That is a massive clinical delta.
It's staggering. And it definitively proves the core thesis of the modern guidelines. ApoB-containing lipoproteins are not merely passive biomarkers. They are the direct causal engines of atherogenesis. When you lower the concentration of the causal driver further, the event rate drops proportionally.
But what about the safety aspect of that physiological floor I mentioned? If we drop them below 55, do their endocrine systems crash?
They do not. And this goes back to understanding human development. We know that human neonates, babies in the womb and shortly after birth, have circulating LDL levels naturally resting in the 20s and 30s.
Wow.
And at that exact moment in their lives, they are growing a central nervous system and synthesizing cellular architecture at an exponential rate.
Clearly, the body doesn't need an LDL of 130 to function optimally if a growing infant thrives at 30.
Precisely. The human body is incredibly adept at synthesizing the cholesterol it needs locally, in situ, inside the specific tissues.
Like it makes it on demand.
Exactly. The adrenal glands, the gonads, the brain, they produce their own cholesterol. They do not rely on massive, unnatural concentrations of circulating LDL in the blood to supply their tissue needs. It is only our modern, highly processed environment and sedentary lifestyle that artificially pushes the population average LDL to 120 or 130.
So a level of 55 isn't abnormally low. A level of 130 is abnormally high.
That's exactly how we need to look at it.
Okay, the target for secondary prevention is sub 55. The biological rationale is totally sound. But let's look at the clinical reality in a primary care setting.
Yeah, it gets tricky.
Getting a patient with a baseline LDL of 160 down to under 55 using just a generic high-intensity statin, say 40 milligrams of rosuvastatin, is mathematically very difficult. The liver can only upregulate so many receptors in response to blocking HMG-CoA reductase. How do we physically force the biology to achieve this new rigorous standard?
This is where we transition from standard monotherapy into the escalation cascade.
The cascade!
Right. The 2026 guidelines lay out a very clear sequential pharmacological pathway. If a maximally tolerated statin does not get your patient below the 55 threshold, the immediate next step is not to throw up your hands. The next step is ezetimibe.
Ezetimibe works entirely differently than a statin, right? We're moving from the liver to the gut.
Exactly. Ezetimibe targets a specific transport protein called NPC1L1, which sits on the brush border of the small intestine.
Okay.
This protein is responsible for absorbing dietary cholesterol and biliary cholesterol back into the bloodstream. By blocking NPC1L1, ezetimibe prevents that absorption. So now you have dual pathway inhibition.
You're blocking the synthesis in the liver with the statin and blocking absorption in the gut with the ezetimibe.
Precisely.
But even with dual pathway inhibition, many high-risk familial hypercholesterolemia patients or simply refractory patients will still not hit that sub-55 goal.
They won't. And that is exactly where the third step of the escalation cascade comes in the PCSK9 inhibitors. This is the domain where the entire treatment landscape is undergoing a total revolution right now.
We really need to spend some time here because the mechanism is fascinating. The word inhibitor is doing a lot of heavy lifting. Let's start with what PCSK9 naturally does in the body.
Okay, so PCSK9 stands for proprotein convertase subglycine type 9. It's a protein primarily secreted by the liver into the bloodstream. Earlier, we talked about how the liver deploys LDL receptors to grab ApoB particles and pull them out of the blood.
Right. The workers on the factory floor pulling the submarine out of the water.
Yes. Normally, once an LDL receptor pulls a particle inside the cell, the particle is broken down and the receptor recycles itself back to the surface of the cell to grab another one.
Oh, reuses them.
Exactly. A single receptor can recycle up to 150 times.
Wow.
But PCSK9 is a regulatory protein that binds to the LDL receptor along with the LDL particle. When PCSK9 is attached, it acts like a biochemical death sentence for the receptor.
A death sentence?
Yeah, it marks the receptor for degradation inside the cell's lysosomes. The receptor is destroyed and cannot recycle back to the surface.
Okay, let me use my analogy again. If the LDL receptors are the workers pulling cholesterol out of the blood, PCSK9 is the middle manager walking onto the factory floor and firing those workers at the end of the day.
That's brilliant, yes.
By inhibiting PCSK9, you are essentially firing the middle manager. The workers, the receptors, stay on the factory floor indefinitely, they keep recycling, and LDL clearance skyrockets.
It's a phenomenal analogy, and the discovery of this pathway is actually one of the great triumphs of modern genetics.
How did they find it?
Researchers initially found families with incredibly high rates of early heart attacks and discovered they had a gain-of-function mutation in the PCSK9 gene. Their bodies produced too many middle managers, destroying all their LDL receptors.
Tragic.
But conversely, they found individuals with loss-of-function mutations who produced almost no PCSK9. These individuals had lifelong LDL levels in the 10s and 20s and virtually zero incidence of heart disease, with perfectly normal lifespans and cognitive function.
So the pharmaceutical industry realized if we can artificially mimic that loss-of-function mutation by inhibiting the PCSK9 protein, we can drive LDL down to neonatal levels.
Exactly.
And up until recently, the only way to do that was with monoclonal antibodies, injectable drugs like evolocumab or aliricumab.
Correct. The injectables are spectacularly effective, but they have major logistical hurdles. I mean, they are large molecule biologics. They're expensive. They require cold chain refrigeration. And fundamentally, a massive portion of the patient population will simply balk at the idea of self-administering a subcutaneous injection.
Which brings us to the breaking data from the CORALreef Lipids trial, highlighted in Dr. Albert's notes. This trial focuses on a drug called enlicitide. Why is this molecule such a game changer?
Enlicitide is a categorical breakthrough because it is the world's first oral PCSK9 inhibitor to successfully pass phase 3 clinical trials.
An oral pill?
Yes. Creating an oral version was considered biochemically excruciating. PCSK9 inhibitors are peptides, and the human stomach is essentially a vat of hydrochloric acid designed specifically to break down peptides.
Right, it digests it.
Designing a molecule that could survive the gastric environment, get absorbed into the bloodstream, and effectively bind to PCSK9 was a monumental bioengineering task.
And the data from the CORALreef Lipids trial proves that they actually pulled it off. Let's look at the numbers. At 24 weeks, patients taking oral enlicitide showed a massive 57.1% reduction in LDL-C compared to a 3% increase in the placebo group.
It is profound efficacy. To put it in clinical context, 67.5% of the patients taking this oral medication successfully hit that aggressive, less than 55 target we discussed earlier.
And the safety.
Crucially, the safety profile, including liver enzymes and muscle markers, was statistically equivalent to placebo.
But the true test of any new drug isn't just against a sugar pill. How does it perform against the actual existing standard of care? That is where the sister trial, CORALreef AddOn, comes in.
Right, the CORALreef AddOn trial is what truly contextualizes the power of this new tool. The investigators ran enlicitide head-to-head against the other common add-on therapies in the escalation cascade.
So what were the comparators?
They used bempedoic acid alone, ezetimibe alone, and the combination pill of bempedoic acid plus ezetimibe. All of these were tested on top of background maximally tolerated statin therapy.
A true clash of the titans for lipid lowering. What were the results?
Enlicitide completely outclassed all the active comparators. It delivered a 64.6% reduction in LDL at 56 days.
64.6%.
Yeah, that was 28 to 57 percentage points greater than the reductions seen with the other therapies. When you look at the primary goal of the guidelines, getting the patient under 55, a staggering 78.2% of patients on the oral PCSK9 inhibitor reached the target.
And the combo pill?
Contrast that with only 20% of patients who reached the target on the combination of bempedoic acid and ezetimibe.
I was looking at these numbers, and the shift in capability is difficult to overstate. It isn't just an incremental improvement.
No, it's a leap.
It's like moving from dial-up internet to fiber optic broadband. You are suddenly giving primary care physicians a tool in a simple, daily oral tablet that used to be the exclusive, hard-to-navigate domain of specialized lipid clinics handling complex prior authorizations for injectables.
It democratizes profound lipid lowering. If we map this onto population health, the implications are staggering. And the timing is critical because the data is telling us that we need to deploy these powerful tools much earlier in the disease process. We have to stop waiting for the vessel to become 90% occluded before we act.
This perfectly segues into the VESALIUS-CV subgroup data that Dr. Albert emphasizes. I had to read this study twice because it completely flips the script on how we utilize heavy artillery lipid-lowering tools.
VESALIUS-CV is a paradigm-altering trial. They utilized evolocumab, one of the injectable PCSK9 inhibitors, but they tested it in a primary prevention population.
Not secondary.
Right. Specifically, they looked at patients with diabetes who had absolutely zero known atherosclerosis. They hadn't had a heart attack. They had no known stents, no strokes, no established cardiovascular disease.
Why are we deploying a heavy hitter like a PCSK9 inhibitor in people who haven't even had a cardiovascular event yet?
Because of the results. Even in this primary prevention cohort, driving the LDL down with evolocumab reduced the risk of a first major adverse cardiovascular event by 31%.
A 31% reduction in first-time events.
It is monumental. It proves that aggressive, profound lipid lowering with PCSK9 inhibition isn't just a salvage operation for patients whose coronary arteries are already heavily diseased and calcified. Extending this physiological benefit upstream prevents the disease from manifesting clinically in the first place.
When you combine the upstream primary prevention data of VESALIUS-CV with the oral, simple accessibility of enlicitide from the CORALreef trials, the future of preventive cardiology looks entirely different.
It really does.
We understand the biology, we have the tight, evidence-based targets, and now we have the accessible tools to hit them.
The clinical, genetic, and pharmacological rigor is, at this point, airtight.
But, and this is the massive, unavoidable but that Dr. Albert builds his entire series around.
Here we go.
If the clinical rigor is so strong, if the data is this unanimous, and if the tools are this miraculous, why the profound resistance? Why are clinicians fighting a daily exhausting war over medications that can prevent a third of all first-time heart attacks in high-risk populations? We have to pivot now from the substance to the noise.
We do.
Because out there in the real world, the internet has armed patients with 4 specific, terrifying fears: muscle damage, memory loss, cancer, and diabetes.
And as clinicians and medical professionals, we cannot simply roll our eyes at these fears. Dismissing a patient's anxiety is therapeutic malpractice. If we're going to extract the substance, we have to systematically, respectfully, and scientifically dismantle the noise.
Let's start with the loudest noise of all, the one that every single primary care provider deals with on a daily basis: muscle damage, myopathy. Almost every clinician listening has had a patient sit on the exam table, refuse a refill, and say, "Doc, I stopped the statin because my legs ache."
Oh, constantly.
What is the actual reality versus the internet hype here?
The discrepancy between public perception and biochemical reality regarding statin myopathy is vast. Let's define the terms. True, severe myopathy, where there is objective, biochemically verifiable muscle damage indicated by drastically elevated creatine kinase levels, occurs in less than 0.1% of patients on standard statin doses.
Less than 0.1%.
Yes. And rhabdomyolysis, which is the catastrophic breakdown of muscle tissue that floods the kidneys and causes the renal failure that internet forums warn everyone about, that has an incidence rate of roughly 1 to 4 per 100,000 patient years. It is exceedingly incredibly rare.
But the patients do feel pain. They aren't lying. The aches in their thighs and calves are subjectively real to them. So if true myopathy is a statistical ghost, where is this massive clinic-choking epidemic of samstatin-associated muscle symptoms actually coming from?
To answer that, we have to examine 2 of the most elegantly designed definitive trials in modern medicine, the Samson and statin-wise trials.
Love these trials.
They are brilliant. These were N-of-1 trials, essentially blinded re-challenge studies designed specifically to solve this exact mystery.
Walk us through how an N-of-1 trial is actually constructed physically, because the methodology is so clever.
In a traditional randomized trial, you compare a large group of people taking a drug to a completely different large group taking a placebo, and you average the results. But in an N-of-1 trial, the individual patient serves as their own internal control group.
Okay, so how do they do it in Samson?
In the Samson trial, investigators recruited patients who had a documented, verifiable history of quitting statins due to severe, intolerable muscle pain. They gave each of these patients 12 identical pill bottles to take over the course of 1 year.
12 bottles for 12 months. What was inside them?
4 of the bottles contained a daily dose of a statin atorvastatin, 20 milligram. 4 of the bottles contained an identical-looking placebo, a sugar pill, and 4 of the bottles were completely empty. The patient took no pills at all during those months. The order was entirely randomized, and crucially, the patient had no idea which bottle they were opening each month. Throughout the year, they tracked their daily muscle symptom scores on a dedicated smartphone app, rating their pain from 1 to 100.
So the patient is blindly rotating through actual active pharmacology, an inert sugar pill, and a period of entirely unmedicated baseline. They're logging their pain every single day. What did the data output from that app actually reveal?
The findings were paradigm-shattering for clinical lipidology. When the investigators unblinded the data and matched the symptom scores to the months, they found that the pain scores during the months the patients took the inert placebo were virtually identical to the pain scores during the months they took the active statin.
Wait, the sugar pill hurt just as much as the statin?
Exactly. Both the statin months and the placebo months had significantly higher pain scores than the empty bottle months. The mathematical conclusion of the Samson and statin-wise trials demonstrated that up to 90% of the symptom burden in statin-associated muscle symptoms is entirely nocebo-mediated.
Let's explicitly define that term. The nocebo effect. It's the dark reflection of the placebo effect.
Yes, it is.
Just the expectation of harm, a seed planted by a Facebook group, a sensationalized podcast, or a well-meaning but misinformed neighbor causes the brain's pain matrix to generate actual physical nociceptive signals when the patient swallows a pill.
Precisely. And it is crucial to understand that we are not saying the patient is faking it. Neurologically, the patient is absolutely experiencing the sensation of pain. But the pharmacological agent, the molecule inhibiting HMG-CoA reductase in the liver, is not the biological cause of that pain. The psychological expectation is.
But let me push back here on behalf of every primary care doctor in the trenches. How does a clinician explain the nocebo effect to a patient who is sitting in front of them wincing in pain without sounding incredibly dismissive?
It's delicate.
Right. You can't just look at a patient and say, the Samson trial proves it's all in your head, take the pill. That destroys the therapeutic alliance instantly. The patient will just leave and find a new doctor.
You are absolutely right. And weaponizing trial data to dismiss a patient is terrible medicine. You have to validate the subjective symptom while gently redirecting the objective attribution.
How does that sound in practice?
You tell the patient, I believe you. I can see that your legs hurt and your pain is entirely real. But based on the highest level of clinical testing, we know the molecule in this pill is statistically not the physical cause of muscle breakdown. Let's explore the actual root causes. Let's look at your vitamin D levels, your thyroid function, your recent physical activity changes, or biomechanical issues. You don't dismiss the pain, you dismiss the statin as the culprit.
That is a brilliant way to handle it. But what if they genuinely cannot get past the psychological hurdle, or what if they fall into that fractional percentage of true, biochemically verified intolerance? We can't just leave them exposed to cardiovascular risk.
We do not leave them exposed. The clinical pivot is swift, and this is where biological innovation saves the day. You immediately transition the patient to bempedoic acid.
Bempedoic acid.
Yes. Bempedoic acid is a non-statin oral medication, and the CLEAR Outcomes trial showed it delivers a 13% relative risk reduction in major adverse cardiovascular events, specifically in statin-intolerant patients. It is now a Class 1 recommendation in the ESC/EAS guidelines.
But wait, bempedoic acid works on the exact same cholesterol synthesis pathway as statins, just one step upstream, right? It inhibits an enzyme called ATP citrate lyase. Why wouldn't it cause the exact same muscle pain?
Because of a masterful piece of pharmacological engineering, bempedoic acid is a prodrug.
A prodrug?
Think of a prodrug as the locked box. The drug is completely inert and inactive as it travels through the bloodstream. The biological key required to unlock that box and activate the drug is a very specific enzyme called ACSVL1.
Okay, so where is that key?
Here is the magic: that specific enzyme exists in high concentrations in the liver, but it's completely biologically absent in skeletal muscle tissue.
That is incredible. So the drug circulates through the muscles, but it physically cannot unlock and activate there. It only turns on once it reaches the liver.
Exactly.
Yeah.
It systematically bypasses the mechanistic possibility of skeletal myopathy entirely. It is a biological workaround for statin intolerance.
Okay, so that thoroughly dismantles the muscle myth and gives clinicians a clear escape hatch. Let's move to fear number 2, which is arguably even more existentially terrifying for patients than muscle aches: cognitive decline. Dementia.
Oh, this one is huge online.
The internet logic goes like this. My brain is largely made of fat and cholesterol. Statins lower cholesterol. Therefore, statins are starving my brain of its fundamental building blocks and causing memory loss.
The biological logic sounds highly plausible to a layperson, which is exactly why the myth is so sticky and hard to eradicate. But the clinical data shows it is unequivocally, provably false. To address this, we look at the CTT Collaboration 2026 data.
What's the CTT?
The Cholesterol Treatment Trialist Collaboration. They performed an enormous meta-analysis of 19 blinded randomized controlled trials encompassing over 123,000 patients. They specifically hunted for any signal of cognitive impairment.
And what did they find across 123,000 patients?
They found 0 FDR significant signal for cognitive impairment. None.
Wait, let's translate FDR significant for a second, because that statistical nuance is important. We're talking about the false discovery rate.
Yes. When researchers run thousands of statistical tests on a massive data set of 123,000 patients, looking at every conceivable variable, you might find random, ghostly signals of memory loss just by mathematical accident.
Just the sheer law of large numbers.
Exactly. The false discovery rate correction is a stringent statistical filter designed to weed out those mathematical ghosts. It ensures that any signal you find is a true, robust biological effect, not a random anomaly.
And even after scouring the data with that level of rigor, they found absolutely nothing linking statins to cognitive decline.
0 evidence of harm.
But the data goes even further than just proving a lack of harm. This is the part of Dr. Albert's notes that truly surprised me. Look at the Ebbinghaus-Ohl trial.
The Ebbinghaus-Ohl trial is the nail in the coffin for the dementia myth. This trial followed patients for 7 years who were taking PCSK9 inhibitors and driving their LDL to incredibly low levels, reaching concentrations below 25 milligrams per deciliter.
Wow. Under 25.
Yeah. The hypothesis of the internet would suggest these patients should be vegetative. Instead, extensive neurocognitive testing showed absolutely no impairment in memory, executive function, or processing speed, even at those subterranean cholesterol levels.
And then there's the Novak et al. Cohort published in 2026. This fundamentally flips the narrative from defense to offense.
It is a phenomenal piece of epidemiological research. The Novak study looked at a real-world cohort of over 838,000 patients across 3 completely independent healthcare datasets. They were looking at incident risk of Alzheimer's disease.
So what was the association?
They found that statin use was associated with a 31% lower incident risk of Alzheimer's disease. The relative risk was 0.69. And crucially, all 3 independent massive datasets pointed in the exact same direction.
So not only are these drugs not causing dementia, they appear to be powerfully neuroprotective. Let's go back to the cellular biology for a second, because we had to explain why the internet logic is wrong. Why wouldn't lowering blood cholesterol starve the brain? The brain is 20% of the body's cholesterol.
It comes down to anatomical compartmentalization. The brain essentially operates its own completely closed-loop cholesterol ecosystem. Circulating LDL in the bloodstream does not cross the blood-brain barrier. The brain does not rely on hepatic LDL for its cholesterol needs.
So where does the brain get it?
The brain synthesizes its own cholesterol in situ, internally, primarily via glial cells called astrocytes.
The astrocytes.
Right. The astrocytes manufacture the cholesterol and shuttle it to the neurons. Because the blood-brain barrier is intact, aggressively lowering systemic blood cholesterol with a statin or a PCSK9 inhibitor has virtually no impact on the central nervous system's internal supply.
That makes perfect sense. So if it isn't starving the brain, where is that 31% reduction in Alzheimer's risk coming from?
We believe it is fundamentally vascular. A massive component of cognitive decline in the elderly is driven by microvascular disease, tiny infarcts, and atherosclerosis in the cerebral vasculature that slowly choke off blood flow and oxygen to brain tissue over decades. By drastically reducing systemic ApoB, statins prevent that cerebral atherosclerosis.
It's essentially vascular dementia prevention disguised as a cholesterol pill. You're keeping the pipes to the brain clean, which preserves the tissue. It's incredible. Okay, so myopathy is overwhelmingly a nocebo effect, and cognitive decline is a complete biological myth stemming from a misunderstanding of the blood-brain barrier. Let's transition to the second half of our noise-cutting session, cancer and diabetes.
Right. If we've established that manipulating cellular pathways doesn't cause dementia, the other great systemic fear patients have is that we will trigger uncontrolled cellular growth.
Cancer. It's a primal fear. Does altering the mevalonate pathway trigger oncogenesis?
We can dismantle the cancer fear swiftly and definitively with the same CTT collaboration data. They looked at 21 randomized controlled trials with nearly 130,000 patients, tracking cancer incidence and mortality over years of follow-up.
And the result?
Absolutely no increased cancer incidence and no increased cancer mortality. There is no confirmed, robust causal mechanism for statins to induce oncogenesis. In fact, if we look at emerging observational data in preclinical models, there are actually hints of a possible protective signal for certain malignancies.
Wait, protective?
Yes, specifically colorectal, endometrial, and aggressive prostate cancers.
What would be the biological mechanism for a protective effect?
Well, rapidly dividing cancer cells have an incredibly high metabolic demand. They require massive amounts of cholesterol to build new cell membranes for tumor growth. By systemically restricting the availability of cholesterol, there is a hypothesis that statins may essentially starve the tumor microenvironment of a key building block, slowing proliferation.
That perfectly illustrates how the internet noise completely inverts scientific reality. The 2 diseases patients are most terrified of, dementia and cancer, are the very pathologies these lipid-lowering drugs might actually be helping to mitigate or prevent. It is a tragedy of misinformation.
It is a profound tragedy. But as clinicians, we must maintain our intellectual credibility. We cannot simply act as cheerleaders for pharmacology and wave away every single patient concern as a myth. We have to be brutally honest when a risk is actually real.
Right.
And that brings us to the fourth and final fear, diabetes.
Right. In Dr. Albert's notes, he puts a massive warning icon next to this section. He explicitly writes, quote, "This one is real. We have to take it seriously."
It is entirely real, and it requires nuanced mathematical risk-benefit analysis in the clinic. The landmark papers establishing this risk are Sedar et al., published in The Lancet in 2010, and Price et al. In JAMA in 2011.
What do those papers show?
The data clearly demonstrates that there is a roughly 9 to 12% relative increase in the risk of new-onset type 2 diabetes among statin users. And that risk is dose-dependent. It is higher with intensive, high-dose therapy compared to moderate-intensity therapy.
Let's break down the why. We've explained the mechanisms for everything else. How does a liver medication end up affecting blood sugar and the pancreas?
The pathophysiology is multifaceted, but the leading consensus focuses on the pancreatic beta cells, the cells responsible for synthesizing and secreting insulin. We believe that certain statins can enter the pancreatic beta cells and interfere with the voltage-gated calcium channels.
Okay, the calcium channels.
Right. Calcium influx is the trigger that tells the beta cell to release insulin into the blood. By interfering with that channel, the statin slightly blunts insulin secretion. Additionally, there is evidence that statins may mildly decrease peripheral insulin sensitivity in muscle and fat tissue.
So you have slightly less insulin being secreted, and the tissues are slightly more resistant to the insulin that is there. Over time, in a patient who is already pre-diabetic, that pushes their A1C over the diagnostic threshold of 6.5.
Exactly. It accelerates the onset of diabetes in patients who were already heavily predisposed due to metabolic syndrome, obesity, or genetics.
So a 9 to 12% relative increase. How do we weigh this clinically? Because now the patient has a perfectly legitimate data-backed point. They are sitting there saying, you are giving me a pill to save my heart, but the data says it might break my pancreas.
That is exactly the conversation you must have with the patient using the rigorous math of number needed to treat, the NNT, versus the number needed to harm, the NNH.
Walk us through that math. If I am treating a high cardiovascular risk population for 5 years, what does the ledger actually look like?
When you run the statistical models on high-risk patients, the data overwhelmingly favors maintaining the statin. The consensus is that for every one case of new onset diabetes incidentally caused by the statin therapy, you prevent roughly 6 to 7 major cardiovascular events.
Let's be very clear about what those events are. We are talking about preventing 6 or 7 myocardial infarctions, ischemic strokes, or cardiovascular deaths.
Yes. You are trading a 1 in 7 risk of inducing one metabolic diagnosis, type 2 diabetes, which is highly monitorable and highly treatable with lifestyle changes, metformin or GLP-1 receptor agonists, for the guaranteed prevention of 6 or 7 catastrophic, irreversible, potentially fatal arterial plaque ruptures.
It's an aggressive triage calculation.
It is. Furthermore, we also have pharmacological nuance within the statin class itself. If you have a patient who is highly insulin-resistant, borderline diabetic, or profoundly metabolically unhealthy, you do not have to use a statin that heavily penetrates the pancreas.
Explain that distinction. Why do some statins affect the pancreas more than others?
It comes down to whether the statin is lipophilic, meaning fat-soluble, or hydrophilic, meaning water-soluble. Lipophilic statins like atorvastatin and simvastatin can easily diffuse across cell membranes throughout the entire body, including penetrating the pancreatic beta cells.
Okay.
Hydrophilic statins like rosuvastatin and specifically pitavastatin are much more liver selective.
Yeah.
They require specific transport proteins to enter a cell, so they don't freely diffuse into the pancreas as easily.
So they stay focused on the hepatocyte where they belong.
Exactly.
Yeah.
The data strongly suggests that pitavastatin in particular may be completely metabolically neutral, lacking that diabetogenic signal almost entirely.
That is a phenomenal clinical pearl. If a patient is terrified of the diabetes risk or their A1C is creeping up, you pivot to pitavastatin. Which brings me to Dr. Albert's clinical rule of thumb regarding this entire debate. It is so clean, and it perfectly encapsulates the clinical triage. He writes, quote, "Never stop the statin, treat the diabetes."
It is the only logical conclusion when you analyze the NNT-NNH math. You do not abandon the ship that is actively keeping the patient from having a fatal myocardial infarction simply because it caused a minor manageable metabolic leak.
You patch the leak.
You patch the leak. You aggressively manage the metabolic risk with dietary interventions, weight loss, and modern anti-diabetic pharmacology, but you absolutely maintain that life-saving lipid-lowering therapy.
So we have covered a massive expanse of clinical ground today. We have journeyed from the depths of hepatocyte biology and Mendelian randomization through the rigorous 2026 guideline targets, all the way into the psychological warfare of the nocebo effect. Let's distill this comprehensive discussion into actionable, high-yield takeaways for the clinicians and informed patients listening.
Okay, pearl number 1 is a fundamental biological paradigm shift.
Yeah.
LDL and ApoB are not passive bystanders or merely markers of disease. They are the causal, physical engines of atherosclerosis.
Right.
Because of that undisputed causality, the target floor has dropped dramatically. The 2026 guidelines dictate an LDL of less than 55 for secondary prevention, and the physiological data proves that lower is unequivocally better. Critically, the tools to achieve those aggressive targets are evolving rapidly. We are moving beyond standard monotherapy into an era of oral PCSK9 inhibitors like enlicitide, which gives us the unprecedented power to achieve these targets in the vast majority of patients without the barrier of injections.
Pearl number 2, we have to confidently and scientifically cut the noise in the exam room. Statin-associated muscle symptoms are overwhelmingly up to 90% nocebo-mediated, driven by psychological expectation rather than pharmacology. Validate the pain, but change the attribution. And if necessary, utilize biological workarounds like the liver-specific prodrug bempedoic acid.
Exactly.
Furthermore, the internet fears regarding cognitive decline in cancer are clinically unfounded mathematical ghosts. The data shows these drugs may actually be protective in those domains by preserving vascular integrity.
And pearl number 3, maintain intellectual honesty regarding the diabetes risk. The diabetogenic signal of statins is real, showing a 9 to 12% relative increase, primarily driven by beta cell calcium channel interference.
Right, we can't ignore that.
But mathematically, it is vastly overshadowed by the cardiovascular benefits, preventing 6 to 7 major ischemic events for every 1 diabetes case. Utilize hydrophilic options like pitavastatin if necessary, aggressively manage the metabolic risk, but never stop the statin.
Which leaves us with one final thought. I want you to consider the trajectory of these new tools, particularly the upstream primary prevention data of VESALIUS-CV, combined with the profound accessibility of an oral PCSK9 inhibitor like enlicitide.
It opens up a fascinating philosophical and epidemiological question.
Exactly. If we can cheaply, orally, and safely keep a massive segment of the population's LDL at neonatal levels of 30 or 40 starting from their 30s onward, atherosclerotic cardiovascular disease might undergo a fundamental shift in our lifetime.
It really could.
ASCVD could transition from being viewed as an inevitable consequence of aging, the #1 killer of human beings on the planet, into an entirely optional, largely eradicated historical disease.
Much like polio or scurvy. We understand the precise biological mechanism, and we now possess the accessible tools to completely neutralize it before the pathology even begins.
The ultimate bottleneck is no longer the science. We have the data. The question is whether we have the societal trust, the clinical communication skills, and the willpower to fight through the noise and actually deploy it. Misinformation isn't just an academic debate. It is the final barrier to eradicating the world's leading cause of death. Keep looking for the substance, keep cutting the noise, and we will see you on the next deep dive.